COPD is a group of lung diseases that block airflow and make it difficult to breathe. The main cause of COPD is long-term exposure to irritants, especially cigarette smoke. There are two main types of COPD, emphysema and chronic bronchitis. Emphysema is characterized by the destruction of the alveoli, which are tiny air sacs in the lungs, and the walls surrounding them. This leads to air trapping in the lungs, making it difficult to exhale. The airways become inflamed and narrowed, making it difficult to breathe. Both emphysema and chronic bronchitis cause airflow limitation, making it harder to breathe. Smoking is the primary cause of COPD. Emphysema is characterized by the destruction of the alveoli and their walls. Chronic bronchitis is defined by a persistent cough that produces mucus. COPD is a serious condition that can worsen over time. If you smoke, quitting is the best way to prevent or slow down the progression of COPD. Patients with emphysema often appear thin due to weight loss from increased energy expenditure in breathing. Cyanosis, which is bluish discoloration of the skin, is less common in emphysema. Patients use muscles in the neck and abdomen to help with breathing due to difficulty exhaling. The chest may appear barrel-shaped due to air trapping. There will be decreased entry of air and reduced breath sounds upon listening with a stethoscope. Chest X-ray shows hyperinflated lungs, where lungs will be filled with too much air, and a tubular heart. On complete blood count or CBC, hemoglobin or HB is usually normal. ABGs show low partial pressure of oxygen in arterial blood and normal or low partial pressure of carbon dioxide in arterial blood. This indicates type 1 respiratory failure. Patients with chronic bronchitis may be overweight or obese. Cyanosis and edema, which is swelling due to fluid retention, are more common in chronic bronchitis. Rhonchi are coarse, low-pitched breath sounds often heard in both lungs. There will be decreased entry of air, reduced breath sounds upon listening with a stethoscope. Chest X-ray shows dirty lungs due to increased mucus production. On complete blood count or CBC, HB may be elevated, which is called polycythemia, as the body tries to compensate for low oxygen levels. ABG shows low partial pressure of oxygen and high partial pressure of CO2. This indicates type 2 respiratory failure. Pulmonary function tests or PFTs are essential for diagnosing and assessing the severity of COPD. They measure how well the lungs are working. PFTs are performed before and after administering a bronchodilator, a medication that opens the airways. A significant improvement in lung function, usually a 15% or greater increase the FEV1 forced expiratory volume in 1 second, indicates reversibility. Cessation of smoking is the most important step in managing COPD. Smoking is a major cause of COPD, and quitting can slow down the progression of the disease and improve symptoms. Patients with COPD should get vaccinated against pneumococcal disease, influenza, and COVID-19 to reduce the risk of infections. The choice of medication depends on the severity of COPD as assessed by FEV1, which is forced expiratory volume in 1 second. In mild case of COPD where FEV1 will be 50 to 79%, ipratropium bromide, which is a long-acting muscarinic antagonist or LAMA, is a drug of choice. In moderate case of COPD where FEV1 will be 30 to 49%, and the ipratropium bromide plus low-dose inhaled corticosteroids and long-acting beta agonists will be the drugs of choice. In severe COPD, FEV1 will be less than 30%, and the drugs of choice will be ipratropium bromide plus low-dose inhaled corticosteroids plus long-acting beta agonists and theophylline orally plus short course of oral steroids for 2 weeks. Long-term oxygen therapy is indicated in severe COPD, pulmonary hypertension, cor pulmonale, which is the right-sided heart failure due to lung disease, and terminally ill patients. Oxygen delivery should be low-dose oxygen 1 to 3 liters per minute. Target oxygen saturation should be 88 to 92%. Schedule should be 14 to 16 hours per day. For oxygen delivery, oxygen cylinders or oxygen concentrator devices are used. Long-term oxygen therapy has been shown to improve survival in patients with severe COPD. Surgical management is indicated such as bulectomy, which is the removal of large air-filled sacs, which are called bullae in the lungs. Lung volume reduction surgery is the removal of portion of the lung to improve lung functions. A last option is the heart-lung transplant, replacement of both lungs and heart.